afternoon, and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually, we have a sign-in link for you to click on to record your registration today. If you have a question and you're viewing online, please enter it into the Q&A chat and we'll ask that question for you at the end. It is my pleasure to introduce our guest speaker, Dr. Hussain Majeed. Dr. Majeed is a third-year internal medicine resident here at Northeast Georgia Medical Center. He is from Montreal, Canada, and completed medical school in the United Arab Emirates. He is interested in advancements in cardiac devices and implementation of technology in our day-to-day medical practices. He is currently pursuing a fellowship in cardiology. Join me in welcoming Dr. Majeed.
Good afternoon, everyone. Thank you very much for this intro. Again, I'm Hussain Majeed. I'm a PGY3 in internal medicine. And today we're going to be diving into heart block and cardiac pacemakers and implantable cardioverter defibrillators, or ICDs. Starting off, I don't have any financial disclosures. First of all, for our table of contents, we'll be going over some of our learning objectives today and reviewing heart block, followed by pacemakers and ICDs. We'll go over some of the landmark trials that brought up the implementation of pacemakers and ICDs into the current guidelines that we have right now, followed by some exciting kind of advancements in upcoming devices that we can look forward to in the near future. Of course, I'm going to ask you some questions and followed by some references in the end. First of all, for some learning objectives. Before that, I chose this topic because it's personal to me. I have a close family member, my father, who, of course, had an unfortunate event when I was younger in my childhood. I really didn't know much about it, and turns out he was admitted to the hospital for complete heart block, and thankfully his life was saved after implantation of a pacemaker, and that has given us many more years together, thankfully. For our learning objectives, we're going to start by defining the different types of heart blocks and understanding their pathophysiology and the level of the pathology there. We'll interpret the different EKGs that we can expect from these heart blocks. And we'll go over and review them since we may be familiar with them. We'll formulate the appropriate management plans for each of these heart blocks and have an idea of when we can start referring patients for device implantation and when to call EP. And finally, we'll talk about the indications and functions and complications of pacemakers and ICDs moving forward. So I'll start off by asking some simple questions. They're relatively simple. So first question, which of the following patients is considered a class 1 indication for permanent pacemaker implantation? So is it the asymptomatic first-degree AV block patient or the third-degree AV block patient with symptoms presumed to be due to an AV block? Is it transient AV block that has resolved, expected to resolve? Is it D, asymptomatic type 1 degree AV block? Or is it persistent first-degree AV block presence of an old or indeterminate bundle branch block? So try to come up with one of your answers and we'll go over them later on. Next question. So which of the following correctly describes the DDD pacing mode in pacemakers? And is it pacing the ventricles, sensing the ventricles, and inhibiting the pacing? Or B, ventricular asynchrony without sensing or responding to intrinsic cardiac activity? Is it C, is it pacing only the atrium and sensing the ventricle? And is it D, pacing both the atrium and the ventricle, sensing both the chambers, and inhibiting or triggering the pacing? Or is it finally E, pacing both the atrium and the ventricle, but only senses the activity in the atrium? Suspenseful, I know. So we'll start off with heart block now. So what is essentially heart block? It's an arrhythmia. It's an abnormal electrical heart rhythm that is mainly pertaining to lower heart rates or bradycardia. That is outside of the full sinus bradycardia, of course. and typically involves a conduction defect within the normal conduction pathway of the heart. And this is just a review. Of course, we're all familiar with that. So our normal pacemaker is the SA node with an intrinsic rate of 60 to 100 beats per minute, and that travels down to the atria through the internodal pathways, and it supplies the left atrium through the Bachmann bundle over here. And moving on to the AV bundle, the AV node where there is a natural delay there. And that moves on to the intraventricular septum through the bundle of His, dividing into the right bundle and the left bundle. And the left bundle divides, of course, into the anterior fascicle and the posterior. And finally, into Purkinje fibers that supplies the ventricles there. Just going back, of course, if the SA node intrinsic rate is abnormal or if it's non-existent, we have backup pacemakers. The AV node, of course, can pace from 40 to 60, and the Purkinje fibers are the slowest, but it keeps a backup pacer of 20 to 40 beats per minute. This is just another review of our EKG pattern. Over here, we've got the SA node firing leading to the P wave or the atrial depolarization here. We've got our PR interval that represents the AV node over here, and then followed by our QRS, which is the discharge that goes through the septum, the His bundle, the bundle branches, and finally the Purkinje fibers. Over here, we can kind of see a true picture of what we can expect from these nodes. You can find the SA node usually at the venocaval, the aortocaval junction over here between the SVC and the right atrium. And then when you cut the heart and expose the right atrium, you can find the AV node there just close by the tricuspid valve. Next up, so we went over this. Heart block is also known as atrioventricular block, is a type of arrhythmia that occurs in patients when their normal electrical heart system is disrupted. So it can cause irregular or slow heartbeats. And usually there is a delay in the disruption in the electrical signals that travels from the atria all the way down to the ventricles. And occasionally it can lead to what we call AV dysynchrony, where the atria and the ventricles are out of sync and they discharge at different times, and that can be very detrimental. So the heart blocks can occur anywhere, usually in the conduction systems, but the most common locations would be the AV node and the bundle branch blocks. Over here we have a kind of a quick and dirty kind of description for the types of heart blocks. We've got first degree, and we can think about it as a slow signal that is still there, but it's slower than usual. Second degree, we can think about it as a sporadic signal. And finally, third degree is just a completely blocked signal that has no synchrony between the atria and the ventricles. Now, how do you diagnose heart block? So there's various clinical presentations given the degrees of heart block. It can range from being asymptomatic, and also usually the patients with early stages of heart block or even just first degree, they may not even know that they have an arrhythmia there. And they are often asymptomatic and detected during routine EKGs, whether you're inpatient or outpatient, noticing those patterns. And we'll go over each one of them and their EKG findings there. Whereas symptomatic cases are usually more advanced here. They depend on the degree of the heart block and the type of block. Patients can come in with syncope, unexplained syncope, and of course, heart block should be one of our differentials there. So we would get an EKG and we would notice that they may have delayed progression, or some kind of AV block there, such as second-degree Mobitz type 2, or even third-degree. They can present with dizziness or fatigue, and that's usually common with bradyarrhythmias because of reduced cardiac output. So patients, especially during exertion, for example, if they can't keep up, they can feel a bit dizzier than usual. Palpitations, patients may even feel that their heartbeats are irregular, especially if they have AV dysynchrony, and that's something that they can present with. And finally, something that we often forget is heart failure exacerbations. I know we think about, coronary artery disease and ischemic cardiomyopathy as being reasons why patients may come in with heart failure exacerbation or volume overload, but you got to think also about electrical connection abnormalities and heart block as being one of the reasons. Especially if a patient comes in with bradycardia, there's just not enough cardiac output and they come in exacerbated. Finally, on physical exam, of course, we note bradycardia. That's our hallmark finding there. And an irregular pulse, usually you can have and that depends on the degree of heart block, from first degree all the way to third degree. You can also notice Canon A waves. It's probably a throwback to med school and our rounds when we get pimped sometimes. And you can see it in the jugular venous distension. If you have dysynchrony there, AV dysynchrony, where the atria and the ventricles are trying to contract, and there's not a normal flow of blood going from the atrial to the ventricles, so you get these pulsations in the JVD known as Canon A waves. Now, EKG interpretations, we will go over those when we go through every type of heart block. But next up would be the diagnostic modalities, and some of these are done inpatient, some of them are done outpatient. A patient may come in your clinic or in the ER and you have unexplained reason for syncope, so you may send them home with what we have here, A, which is the Holter monitor, and these are usually for a duration around 1 to 2 days, 24 to 48 hours, and they're usually ideal for diagnosing intermittent blocks or correlating symptoms with arrhythmias at that point. The issue is that you may miss arrhythmias that are infrequent, especially since it's such a short time frame. So that leads to what we have here in B. The happy gentleman here, the event monitors are usually placed here on the chest, and they are used in patients who may experience symptoms that are less frequent. So you want longer extended durations, and they can last from, for example, several weeks, and can just be stuck to the patient's chest, and this information can be monitored from the actual device company. Whereas over here we have an ILR, an implantable loop recorder. This is done over here as well, and these are similar to the event monitors, but you can expect them for even longer time, sometimes weeks to months to even years. Patients can go home if they have very frequent arrhythmias, and this will catch it. Well, that's the idea. Finally, if they're in the inpatient setting or even outpatient, you can schedule them for what we call an EP study, electrophysiology study, and basically our EP folks here would reserve these for the most complex and ambiguous cases. And it's particularly when you don't want to do, you want to keep it non-invasive to an extent, and well, the non-invasive testing fails and you don't really know the reason for the arrhythmia. So what it does is that there are 4 electrodes that we can see over here. They go down from, it comes up from the IVC into, we have the high right atrial over here. We have his bundle lead over here. We have the coronary sinus that wraps around over here. And finally, the RV apex. And that way they can diagnose and sometimes even stimulate some arrhythmias to see if there's some kind of conduction abnormality and really diagnose complex cases from there. Now, first degrees. We'll go over the EKGs over here. So a first degree block, namely you can find them typically at the AV node. If there's some kind of partial block there, you would diagnose them usually with a prolonged PR interval, so from the P to the beginning of the QRS. Namely, the normal PR intervals are around 120 milliseconds. And when you have longer than that, 120 to 200 milliseconds, when you have longer than 0.2 seconds, then you can diagnose a patient with heart block of first degree. Here it's kind of obvious, you can kind of see it, but over here it may be missed if you don't pay attention because it kind of blends with the T wave, but this is a consistent prolonged PR interval, and it's still first degree, although the PR is significantly elevated and prolonged here. Now we got second degree AV block, or also known as Mobitz type 1, Wenckebach. It's named after the Dutch physician who described it first, Karel Frederick Wenckebach, back in 1899. And over here, the landmark finding that we can expect is a prolonged or a progressively prolonged PR interval that eventually just drops and catches back again, and is followed by QRS interval after that. You can find it over here, usually also at the AV area most of the time, and the block is just more prolonged until the beat is eventually dropped. But these usually catch back on their own as well. For Mobitz type 2, It's also considered second degree, but we divide them, of course, in two types. We've got this usually occurs below the AV node around the His bundle area, and sometimes even in lower areas in the bundle branch areas. And what you can get over here is you get a failure of conduction of the impulse from the SA node all the way down to AV node and below. Usually you find these in patients who've had some kind of structural condition, for example, if they have fibrosis or prior infarcts or necrosis in the area, and the signal usually gets abrupted around this area, around the His bundle. Over here we can see it starting off with over here, the top one, the PR interval, suddenly just drops out of nowhere without any prior kind of warning. The PR interval doesn't look like it's being prolonged, and it just suddenly drops, and then kicks back into gear. And these, we'll talk about them, are usually starting in the more dangerous side. Now, finally, we've got our third degree AV block. And this is just a total complete dissociation between the atrial and the ventricular activities. Usually it indicates that there's a complete loss of communication between them, and the intrinsic rates of the SA node cannot reach the ventricle. So from then on, you have lower intrinsic rates, whether it's the His bundle intrinsic rates or even the Purkinje fibers intrinsic rates. And over here we can see that the P waves representing atrial depolarization are completely dissociated and independent of the QRS intervals, which represent the ventricular depolarizations. So you bring your caliper at bedside or with your EKG in front of your attending, and then you show them that all the P waves are consistent with each other, all the QRSs are consistent with each other, and then you can impress them and tell them that this is complete heart block. But at that point, the patient already has a pacemaker, I think. Next up, we'll talk a little bit about some bundle branch blocks. These can sometimes be a bit difficult to catch, especially if you don't kind of read into them very often and revise them. So past the His bundle, if you have a block that's involving the right bundle or the left bundle, then you can get those subsequent EKG findings. Even the anterior fascicle and the posterior fascicle have their own types of blocks and EKG findings here. Starting with the right bundle over here, we can note that in leads V1 and V2, you can have the typical RSR pattern over here, or RSR prime. And in V5, V6, you look at broad S waves over here, and V5, V6, and you can have secondary STT wave changes as well. Whereas the left bundle, when you look at the V1 and V2, you can see deep and broad S waves or QS complexes, whereas in V5, V6, you can see kind of a broad, clumsy positive R wave. And usually, as almost like a rule, the T wave is in opposite direction of the amplitude of this QRS complex. So you can see the T wave is upward facing, this is downward facing, upward and downward, and that also kind of gives you a hint about that. Now, how do we manage these? It depends on where you are in the management. If it's an acute management, the patient comes in the ER and you're there to kind of take care of it immediately. If it's first degree and second degree, you just observe it, honestly. Usually it doesn't require any intervention if the patient is completely asymptomatic. However, if they present with symptoms, syncope, shortness of breath, and you can't really explain it for other reasons, you might want to keep them in observation to kind of see what's going on and keep them on telemetry to see if there's not a more dangerous arrhythmia there, especially if they come with dizziness or syncope or transient bradycardia that's unexplained. Whereas the Mobitz types 2 and third degree are where the danger lies most of the time. And these can progress to complete heart block where the conduction just doesn't pass through the bundles and supply the ventricles. And you can think about low output cardiac states and heart failure exacerbations. So a patient is at very high risk from there. IV atropine is something we can try to see if we can antagonize the cholinergic system and see if we can bring up that heart rate. But usually they're less effective than just infranodal blocks. Temporary transvenous pacers are something that are usually done also in the ED, where you've called cardiology and there's a dangerous rhythm, but to temporize the time and get them to the ICU, you introduce a transvenous pacer. temporarily to kind of keep it as a bridge to permanent pacing. You can even do it continuously. You can have pacing pads on the patient's chest, and especially in those most dire emergencies, and pace the patient that way. But those are usually painful, but if the patient is already unconscious and you are out of time, that's a good option to have. In the long term, what do you do? Symptomatic bradycardia, continue monitoring. You might want to send them with a event monitor if you need to, but usually it's just outpatient monitoring. For MOBITs type 2 and type 3 and third-degree AV block, typically they need pacing, permanent pacemaker replacement, PPM. Whereas if you have chronic bifascicular blocks or syncope, these also should be paced because they're at high risk of developing into advanced blocks. And of course, EP should be considered for all of these advanced blocks. You need to also consider reasons why they may be having these kind of arrhythmias and bradycardias. Is there a medication that's causing this? Is the patient overdosing on beta blockers at home? Or there's underlying ischemia that's causing this. So base it on your clinical judgment at this point. Now, moving on to cardiac devices. So a pacemaker, what is a pacemaker? Essentially, it's a matchbox-sized device that's implanted between the skin and the pectoral muscles here and the subcutaneous tissues, and it kind of lays there and has a bump over the chest. And it basically takes over the role of the SA node if the SA node is still functional, but there's some kind of block there, or there's complete heart block and there's no connection between the atria and the ventricles. The pacemaker is there to do that, basically. So just as a kind of brief history of where we are in terms of cardiac pacing, usually in the 1950s, they started off with big AC power devices over here that were, of course, inconvenient, and that later transitioned into the later 1950s to smaller wearable ones with transistors. But it all kind of changed once we've had the first implantable one back in 1959. These have then improved over time, and in 2015, this is kind of the standard that we have right now. These are way smaller, the leads are more efficient and more insulated, and of course there's better outcomes with these. In 2016, there's actually been the introduction with the FDA of leadless pacemakers, and these are very exciting. This is, I believe, the Medtronic Micra, who I think started all of this. And now you don't have leads that are running from, the venous system, and you don't have a big matchbox-sized device there. There's just a small leadless pacemaker doing the job. And in the future, there's even talks about having these small patches or pacemakers that are attached to the myocardium that get energy with the contractions of the heart, since it's always beating, and in return, that kinetic energy turns into electrical energy and is able to be paced. Animal trials so far, but there's some very exciting stuff going on. Pacemakers, so components. We can think about them as having two major components. There's a pulse generator and there's a pacing leads. So the pulse generator is the main unit over here, and it's essentially the device, the part that creates the pulse and is usually encased in a biocompatible metal, usually titanium, to minimize the rejections and ensure durability. It would also have, of course, a battery that is usually lithium-ion. Pacemakers can last from 5 to 15 years, even 16 years with some of these other ones, and need to be addressed and replaced after that. And, of course, the battery is what supplies the power needed for the pacing. We've got a circuitry, there's a circuit board here that is able to detect the intrinsic cardiac rhythm and not pace if the pacemaker is kind of kicking in on its own and not bother it, or the opposite, pace it. And the circuitry is also where we can program specific pacing strategies based on what the patient exactly needs. Next up, we've got the leads. These are insulator wires. They carry, of course, the impulses all the way into the areas that you need to be pacing. It could be the right atrium, could be the right ventricular apex, could be the coronary sinus. You can get them wherever you need to get them, and they are also made out of platinum and iridium here, surrounded by silicone and polyurethane. We've got different types of leads. We've got unipolar leads and bipolar leads there, depending on what the typical pacing rhythm that or pacing strategies that you're expecting or what the patient exactly needs. And there's different even fixation methods. Sometimes you may want to use what we call the passive fixation, which is this one over here. It kind of looks like a small hook, and you can see it over here. It kind of attaches and hooks onto the myocardium. And there's even the more active fixation screw, which are screwed into the myocardium here in active form. Next up. Of course, installation is very important because you want to make sure that only the areas that you're intended to give those electrical impulses are being conducted, and you don't want other areas of your heart or your body in general to receive these impulses. And it's also formed with a connection block which connects the leads to the device. MRI compatibility is always something that you're questioned. You get a patient who had a pacemaker placed in 2015, and you don't know if you can send it for an MRI. So then you check with the company or the device rep. And usually MRI-compatible devices were mostly introduced in 2011. And there's been further advancements to kind of minimize the risk of MRI interference. Of course, it's a metallic device, and you're concerned about the complications within the MRI system, the MRI, but you're also concerned about the magnetic impact on the pacer. You don't want the patient to not get the pacing that they need, especially if they're in complete heart block. So, but nowadays, especially if they're after 2011, you can mostly be rest assured that most of them are MRI compatible, but it's always good to check with the rep. These are some of the most commonly used ones. We've got a multitude of different companies: Boston Scientific, Abbott, Biotronic, and Medtronic. And see, these are some of the pacemakers you can expect. They all have essentially the same components, but they have different voltages, they have different pacing strategies, but they all are very similar. Now, what are some of the indications for pacemakers? Essentially, of course, first of all, symptomatic bradycardia. If the patient has heart block and they fail to respond to pharmacologic treatments, you could send them for a pacemaker. Mobitz type 2, second-degree heart block. The concern is that they can develop into complete heart block at that time and be at risk of heart failure and dangerous arrhythmias at that point. And third degree, of course, heart block is also the standard indication for pacemaker placement. Class 1. Of course, we've got also other conduction disorders. Patients may have sick sinus syndrome. You can see that often in a lot of your admitted patients. Their intrinsic pacemaker is not kicking in well enough, so you have to replace the SA node over here. Whereas those patients usually have normal conduction pathways. They can have what we call chronotropic incompetence, where their heart rate just does not accelerate to meet their exercise needs. So you've got some very smart pacemakers out there that can recognize that the patient is exercising and kick up the heart rate as needed as well. And of course, that is very exciting to move forward. Now, there's different types of pacemakers. You can look at single chamber versus dual chamber. Over here, we've got an RV lead. You can see it going all the way to the apex of the RV. You've got the RA lead over here. And these are usually used for patients who need ventricular pacing, such as those with atrial fibrillation or slowed ventricular responses. And these are just one leads. Usually you can have actually dual leads pacemakers, which would be a lead here in the RA and the RV. And these are very common. And usually these are to maintain AV synchrony, to make sure that the atria contracts when it's supposed to, and the ventricle also. Over here we've got the kind of the Cadillac of all pacemakers, CRT, or biventricular pacemakers, which stands for cardiac resynchronization therapy. There's one lead in the right atrium, there's one in the RV apex, and to pace the left ventricle, if there's specific indications which we're going to go through, it actually goes to the coronary sinus and it wraps around the LV here. So it's you've got 3 chambers being paced, and these are usually reserved for patients with severe heart failure with reduced ejection fractions less than 35%, and if their QRS interval is prolonged, if it's more than 150 milliseconds, then there's just dyssynchrony between the right and left side, and you are trying to bring that back into a normal synchronous contraction. These are some of the AHA guidelines. We went through them, basically class 1 recommendations, of course, third degree AV blocks at any anatomic levels, and of course, secondary AV blocks with symptomatic bradycardia. They can also progress into third degree AV block at that point. Class 2A recommendations, sometimes you get asymptomatic third degree AV block at any site, but most of those patients in reality would honestly just get a pacemaker with the third degree. Or if you have asymptomatic type 2 degree AV blocks, you can monitor or opt to proceed with pacemaker placements. Now, how do they work? They have different pacing modes. There's VVI, there's DDD, there's VVO. What do all those letters mean? If you're on cardiology service and you're attending, would like to kind of test you at that point, hopefully we can kind of memorize that at the end of the lecture. The first letter, you can think about it as the chamber that is paced. So what is receiving the paced electrical shock at that point? The second letter is what chamber is sensed as a response or prior to the pacing. And the third letter is what is the action, what is the response to that sensed rhythm for the second letter over here. And we'll go over a whole table over here about the most common pacing methods that we can see. Pacemakers are not without complications, of course. It is a foreign body that's introduced in, as with any foreign body, there are some complications. So one of them is the lead dislodgement, basically, especially after you've implanted, if there is ineffective pacing at that point or inappropriate sensing. And sometimes these leads need to be repositioned and need to be brought back to the EP lab for that. Infections are also another concern there, especially in the pocket of the pacemaker. If that is not kept sterile, or if a patient comes in with bacteremia and sepsis, those leads are foreign bodies. They can be infected, and at that time, they may even need removal of the pacemaker, or actually at least exchange of those leads. Hematomas at the side of the pocket are also one of the complications. Pneumothorax is also another thing we have to keep in mind, especially since you're so close to the apex of the pleura. And finally, pacemaker syndrome. That's something we can also see, especially in some modes, especially the VVI mode, which results basically in AV synchrony, loss of this synchrony. So patients get symptoms of dizziness, hypotension, palpitations. Keep that in mind every time a patient gets a new pacemaker, if their ventricles and their chambers are not in sync. Yeah. These are some of the most common pacing methods. We've got VVI, AAI, and DDD. They are, of course, the first letter represents the chamber that's paced. The second letter is the chamber that's sensed. The third letter is the response to that sensing, whether it's inhibiting or triggering or doing both or doing nothing. And we've got some clinical indications here. I don't want to go over every single one of them, but the most common ones you can see VVI. So the ventricle, it's also called ventricular demand pacing. And basically the ventricle is paced and the pacemaker is inhibited if it senses the intrinsic ventricular activity from there. You can see that mostly in patients with atrial fibrillation and slow ventricular response. AAI is also another pretty common one. The atrium is paced, and pacemaker is inhibited if it senses the intrinsic atrial rhythm, if the SA node is still functioning. So that's really useful. DDD is also one of the most common ones. So both the atrium and the ventricle is paced, and both of them are being sensed. And that really ensures that there's significant synchrony. The pacemaker takes control of everything, and it's used in AV blocks with intact sinus node dysfunctions, but there's a issue with the conduction of the A from the A to the V. We've got also DOO, so both chambers are being paced, but there's nothing being sensed and nothing being, and there's no response to the sensing. And you can see that in patients, this can actually be changed from VVI to DDO, for example. Let's say that they're in a surgery and the anesthesiologist wants complete control of the pacing, so they can set a certain rate to the ventricle and ignore whatever the atrial paced rhythm is and take complete control of that. You may also be asked during rounds, what kind of paced rhythm is this? Is this an atrial paced rhythm? Is it a ventricular paced rhythm? I'm here, I just wanted to add a slide to kind of go over together and hopefully save you a pimped question. So if you see the atrial spike, this line right before the P wave, you can think about it as an atrial paced rhythm, whereas if you see it before the QRS complex representing ventricular defibrillation, you can think of that as a ventricular pacing spike. If you see both of them, you can think about them being both paced. Over here, there's a normal QRS, and you can see atrial pacing over here before the P wave. You can see the ventricular pacing before the QRS over here. And this is DD over here before the P wave and the QRS complex. Now, what else do we have? We are ICDs, so implantable cardiac defibrillators. They are devices that are intended to deliver more often than not, a life-saving shock in a patient who is outside of the hospital setting, of course. And their components are relatively similar to a pacemaker. So you have your usual pulse generator that delivers the shock at specific voltages that are set by the provider who implanted it. We've got, of course, our leads, and there's specific sensing algorithms that detect the arrhythmias and differentiates ventricular tachycardia from VF from normal rhythms. So a patient does not get a shock when they're not supposed to. For example, if they're exercising and they have tachycardia that is normal, or with heart rates reaching in the 180s, for example, or 170s, they don't get an abnormal shock. There's also some other therapies that can be delivered other than shocking. Defibrillation is actually one of the last ones that the ICD delivers. There's ATP, which is anti-tachycardia pacing, and there's also cardioversion, but we'll go over those. And finally, there's a data storage and telemetry component to it, so that when a patient gets shocked, the representative can pull up that information, print it out, and bring it to the patient's care team in the hospital setting to see if there was some kind of dysfunction of the ICD. These are all other example ICDs that we can see commonly used: Medtronic, Biotronic, Boston Scientific. They're very similar to each other, and they're also similar in size to the pacemakers. What are some of the indications? So we've got secondary prevention and primary prevention. ICDs play a crucial role in preventing sudden cardiac death, especially in patients who are at high risk of life-threatening arrhythmias. Let's say they've had a very significant myocardial infarction and their EF is abysmal. They are very much dependent on this ICD to save their life outside of the hospital setting. So for secondary prevention, these are patients who have already experienced life-threatening ventricular arrhythmias, such as sustained ventricular tachycardia or VF, ventricular fibrillation in the field, and they now meet the indication for getting an ICD. The goal is to prevent the recurrence of these life-threatening shocks. Whereas primary prevention is also beneficial in certain high-risk populations, and this is what we try to catch before they need a pacemaker, before they need an ICD or develop one of their first life-threatening arrhythmias. So you can think about them as post-MI patients who have a history of MI with an ejection fraction of less than 35%, especially if they have if they have arrhythmias during their admission period. If you have heart failure patients who have non-ischemic dilated cardiomyopathy or LVEF less than 35%, despite normal medical therapy, ICDs are recommended. Also, patients who have inherited channelopathies, patients with long QT syndromes or Brugada syndromes or catecholaminergic polymorphic VT, CPVT, these patients may also benefit from an ICD implantation here. You usually don't implant those ICDs if the patient has a reversible or known cause of the VTVF, and that's something that can be discussed, especially with EP during the inpatient setting here. How do they work? So there's major two components. There's detection of the arrhythmia, and there's delivery of the type of shock. So there's specific algorithms in the circuitry of the ICD that is able to detect the arrhythmias, and with the years, they become more and more smart at detecting what is truly a dangerous rhythm versus what is a sinus rhythm that may be too fast, or God forbid, for example, just artifact. And so that's the detection part. For the delivery, there's anti-tachycardia pacing. These are, for example, what it is that you may be asked about it. Basically, the ICD tries to take over and give a slightly faster rhythm compared to the patient's current arrhythmia. Let's say they come in with ventricular tachycardia and they're at a rate of 120, for example. The ICD tries to overtake that and give us faster rhythm to kind of abate that rhythm. And that's usually one of the first attempts that the ICD would do. Cardioverter is also possible, especially if it's a shock or an arrhythmia that is amenable to that. Let's say they get atrial fibrillation with RVR, they can get shocked at that point. And of course, defibrillation, where a high energy shock is delivered at specific voltages in an attempt to kind of abate and end those dangerous arrhythmias, namely VF or rapidly progressing ventricular tachycardia. Now, and there's also post-therapy monitoring and logging after that to make sure that there's the care after that. This is what I was talking about, the ATP. So if you look at the left over here, there's a VT that's not really fast. There's white QRSs, and it was detected as ventricular tachycardia. And then the ATP kicks in at this point. It tries to give a rate that's faster than the actual VT to try to abate it. And then from there, it successfully ended it and continued with a V-paced rhythm over here. And this was all without a shock. The patient didn't even know that he had this going on. And these are usually pretty effective, actually, 85 to 90% of efficacy for monomorphic VT. And that the idea is to reduce the need for unnecessary shocks. This is just a PVC here in the end. There's different types of ICDs. There's a traditional ICD that we know that most patients have. And these are implanted in the same area approximately as a pacemaker. And the leads go through the venous system, subcutaneous vein over here, and they attach to wherever they need to be attached, in the RA and the RV. The benefits of this is that there's a pacing capability because the leads are relatively similar, so you can give AT tachycardia pacing or even bradycardia pacing. So you can get a 2-for-1 from there, but of course it's implanted, there's a risk of infection, there's a risk of complications with extraction of the leads if there's a need for that, and there's even lead failure. Whereas over here, relatively newer subcutaneous ICDs, these are also relatively in size. If anything, they're a bit bigger, and they're right below the armpit, under the skin. They kind of stand out, but the benefit is that they're placed right under the skin. There's a lead that is burrowed right under the skin all the way to where the sternum is, and it takes a 90-degree and goes up. This is above the sternum, it's below the skin, it's not in the venous system, and it can be removed relatively easier than subcutaneous, than transvenous ICDs. Of course, because of that, there's a reduced risk of infections, they're easier to remove, but they can't deliver ATP pacing, and they can't deliver bradycardia pacing. So that's a give or take. So you have to choose your patients based on those recommendations. Some of the landmark research trials that developed and helped build the guidelines for both of these devices. So we've got, in 2001, we have the MOST trial that found that the main takeaway was that dual chamber pacing was preferred for sinus node dysfunction due to its benefits in reducing atrial fibrillation, improving patient outcomes. The David 2002 trial noted that in patients with ICD, in ICD patients who didn't need pacing, dual chamber DDD pacing led to worse heart failure outcomes compared to ventricular pacing. So the main takeaway would be that avoiding unnecessary dual chamber pacing in ICD patients without a clear pacing indication actually worsened heart failure. Some more defibrillator combination trials back in 1996, ICDs were found to be effective for secondary prevention and were made as part of the guidelines in the MATA 2002 trial. Patients with ICD and reduced, it found that ICD reduced mortality for post-MI patients and an EF of less than 30%, even without a prior documented arrhythmia. So they became indications for primary prevention at that point. For the SCD HEF trial back in 2005, ICDs are also recommended for primary prevention in heart failure patients with low EF and symptoms. And the Dynamite trial in 2004 found that ICDs should not be implemented actually post-MI. There's been evidence that there's increased risk of sudden cardiac death in up to 40 days, I believe, and ICDs can be considered even after that implantation, but they're usually not normally recommended within that first 40-day window post severe MI. CRT trials, over here, Miracle 2002, CRT was found to be beneficial in heart failure in patients with conduction abnormalities. This companion trial found that CRT-D, which has a defibrillator component to it, which is even more of a Cadillac. CRT reduced the hospitalization and mortality in heart failure patients with EF and wide QRSs greater than 150 milliseconds. And it became the standard of therapy for heart failure patients with significant conduction delays. In 2005, the CARE heart failure trial found that it was essential for CRT in heart failure management, even without ICDs in certain patients. In 2008, the reverse trial found that CRTs was beneficial in patients with mild symptoms by slowing the heart failure progression. So you can even consider CRT therapy in patients who may have earlier stages of symptoms in the NYHA, for example, 1 to 2 stages. The MEDIT CRT trial in 2009 found that CRT was indicated for mild heart failure with dyssynchrony to prevent disease progression as well. So very beneficial overall. For ICD trials in 2004, the trial does not support the ICD used for primary prevention of sudden cardiac death and non-ischemic cardiomyopathy. Whereas the REF trial in 2010 found that CRT with defibrillator function significantly reduces the mortality and hospitalizations in patients with moderate to severe heart failure and wide QRSs, reinforcing the need in advanced heart failure. Some other recent advances in 2016, the leadless 2 trial, which was the main trial that brought in leadless pacemakers, namely the Micro, which is from, I believe, from, was it Boston Scientific? I may be mistaken. Showed that there was a high success with fewer complications, making them more viable options for single chamber pacing. And we'll go over the leadless pacemakers there. The Praetorian trial in 2020 found that subcutaneous ICDs were also as effective as transvenous in preventing sudden cardiac death. And they were safer options for patients with high risk of lead infections. So that's also something to consider here. There's a lot more exciting trials coming up. And this field is constantly expanding with every HRS, Heart Rhythm Society conference every year. There's always something exciting. And that's always one of the main points. So what does the future of therapy look like? We've got conduction system pacing. That's one of the new pacing strategies that we're doing here in the hospital in NGMC. Basically, it involves pacing not necessarily the RA or RV, but it paces anywhere distal to the AV node. So we've got his bundle position over here and the left bundle branch area pacing. And the point of this is to kind of help treat heart failure and bring back cardiac resynchronization. There's some very exciting stuff with this going on, and it's gaining a lot more in popularity, and I think we're moving in this direction, actually, rather than typical right ventricular apex pacing. Leadless pacemakers over here, this is introduced since 2016, and this is the Micra pacemaker. It's very small. It's around 1 3/4 inches. You can see it over here when you get a chest X-ray, and it burrows into the right ventricular apex. There's no need for connection wires. There's a separate power source or a pocket. The battery life lasts from 5 to 16 years sometimes, similar to regular pacemakers. And there's reduced risk of complications, infections, lead dislodgement, of course, because there's no actual lead. Something you got to keep in mind is that the removal of this device needs a specific kind of delivery catheter and removal apparatus to get that out. But it's very exciting. Now over here we've got our dual chamber leadless pacemaker. So if the RA needed to be paced and the RV, you can have 2 of those leadless pacemakers. And for Micra, Abbott actually was FDA approved for this technology to dual pace back, I believe, in July 2023. So this is, I believe, a direction we're moving towards. There's other companies like Boston Scientific that are also coming up with their own leadless pacemakers. I believe they're called Advares here. Another exciting innovation over here, published in the New England Journal of Medicine. There's a leadless pacemaker connected to a subcutaneous ICD, and this has been published in May of this year, actually, in the New England Journal of Medicine. So the idea is that subcutaneous ICDs are great. They have reduced infection rates, but they are not able to do tachycardia pacing. They're not able to do bradycardia pacing. It's just a shock box, essentially. So in a patient who needs that pacing, you actually can implant a leadless pacemaker, and those two devices connect and communicate with each other. So this is very exciting. We may be moving towards the less invasive pathway and getting away from leads altogether. That might be the direction we're moving towards. These are battery-less cardiac pacemakers. Over here on the left, tested currently in animal studies in pigs, but the idea is that this is implanted under the skin. It catches infrared technology or infrared rays, and it actually can deliver shock. This is attached to the myocardium. This is actually kinetic energy converting to electrical energy, and it can pace just by the heart's own contractions. And I think that's really cool stuff. Now, going back to the questions. So which of the following is a class 1 indication for permanent pacemaker implantation? Of course, we have it as B. So symptomatic third-degree AV block is a class 1 indication because of the risk of progression and severity of symptoms needing immediate intervention. Our second one, so what does the DDD pacing mode refer to? And it refers to pacing both the atrium and the ventricle, sensing both of them, and inhibiting or triggering or doing both, or capable of doing both. Now, in conclusion, so we recapped all the main key points and types of heart blocks and their management. We emphasized the importance of timely diagnosis and recognition and calling electrophysiology. And finally, we explored some of the exciting advancements that are coming up in the very near future. I'd like to thank some of my mentors, Dr. Ahn from EP, and of course, Dr. Gross, who've really helped me out throughout the last almost two and a half years. We're almost done. It's been a good time. We're almost done, but thank you very much. And these are some of my references. And do you guys have any questions?
Excellent. Thank you, Dr. Majeed. If you have a question, we'll hand you the microphone. And if you're online, please enter into the Q&A chat and we'll ask for you.
Great presentation, Dr. Majeed. Do have a question. In patients that have ICDs and have arrhythmias and the ICD fires, how many joules does it administer, and is there a certain amount that differs between each arrhythmia, or is it just standard?
That's a good question. In terms of joules, I mean, we know that if you're in the ER, for example, and a patient needs defibrillation, you can go up from 150 joules, 200 joules, sometimes 300 joules. These devices, it depends. So if you have the transvenous pacers, they're right below the skin. The leads go through the venous system and directly connects to the heart. So it can go up to 40 joules, approximately 45 if I'm not mistaken. Whereas if you have the subcutaneous ICD, because it's over the skin, there's more impedance with the chest wall. The lead is above the sternum and below the skin. They can go anywhere from 40 to 60, even up to sometimes I believe 80 joules if I'm not mistaken. But these joules, when they're first implanted, they actually do a test run. Sometimes they induce an arrhythmias, and then they shock and see if that was enough of a joulage or a joule to return to normal sinus rhythm. So yeah, it depends on the type of ICD. Yeah.
Thank you, Dr. Majeed. That was an excellent presentation. That's kind of like a perfect example of what I hope to see in these Grand Rounds presentations, just kind of a simplified literature review, most up-to-date evidence, taking us through, and you can tell your passion, your interest in this area, the way that you presented it. So yeah, just fantastic job with the presentation. And I guess one question came up, MRI compatibility. It seems like that's always that slows down a patient's admission, checking for MRI compatibility, but it seemingly that's really shouldn't be an issue, like in the future. If 2011, they're all compatible. Is that your understanding?
Yeah, that's a great question. I mean, there's always that fear. You don't want to be the one to send a patient to the MRI and have complications because you didn't take the extra step. I think it's going to be just the standard at that point. All of them are MRI compatible, and most of them actually have an MRI setting where the pacemaker can be set to deliver pacing without being interfered by the magnetic resonance from the imaging. So, but I always have that indwelling fear that I have to check this is MRI compatible or not, definitely. Yeah.
So I don't have question, but comment. Really excellent presentation, and it's really, as Dr. Gross is saying, a good example for every level to get something from this presentation. And I think that's a really good message for our third years at what should be the grand round, so that everybody get benefit from lower level to really high, and having including all the trials and everything. Thank you so much.
Thank you, Dr. Dav.
All right, thank you, Dr. Majeed.
Thank you.